Very good evening, my dear students. Welcome all of you. I hope I am audible and visible to all of you. So, welcome to this great session on dermatology. So, this is going to be a great session for dermatology with all the most important topics that is important for your NEET PG 2024. I, I hope all of your preparations are going fine. So during this, difficult times when the date of the exam has been changed, and again you may be feeling much difficulty in the preparations and all. So this is an attempt where what I've done for today's session is I have just picked up the most important topics in dermatology. The most important topics, which you may guess that these are the topics which is most probable for this 2024 NEET PG exam. So myself, I'm Dr. Jazeer Abdul Qadir, your dermatology faculty at Physicswala Medit. And during this session, what I intend to do is I'm planning to just interact with you, do multiple questions from different topics. And when we do each and every MCQ, we will also try to cover the most important points of that disease. Fine. Uh, Fine. Good to go. No problem. Center nahi mila. All these things. Just concentrate on the subject right now, and then once it is done, I'm sure that you will get your center and you will also rock the exam as well. Fine. So now let's start with the first topic of the day. Obviously, we are talking about the subject dermatology. So every exam, be it INI-CET or NEET PG or FMG, in every exam, this one's topic is always repeated, right? So this is what is this topic? The moment you see this image, some of you would be able to say ki kya diagnosis hai. What is the diagnosis? Anyone who is watching this video? Yeah, what is the diagnosis? Yes, the diagnosis is going to be psoriasis. Now let's read the question first, that a 35-year-old male presents with the following skin lesions. Which histopathological finding is characteristic of this condition? So they have given you an image and they have said that it's a 35-year-old male. Now we have to make out what is the diagnosis based on the image. So we have already discussed key diagnosis here is going to be psoriasis. So we are going to start our discussion with the first topic, that is psoriasis. Now what is asked in this MCQ is the histopathological findings. Now let us read each and every option. Munro microabscess, severe T bodies, Portrea's microabscess, and lipid-laden macrophages. So what is most likely in psoriasis? Now let us discuss what is possible. Now, first of all, why do you say that when you see this image, what makes you say that this is going to be a case of psoriasis? I'll just zoom it for you. You can see what is happening here. There is some erythematous plaque in the background. Along with that, you can see that there is very shiny plaques, right? What do we call for these kind of scaling? This type of scaling is called as silvery white scales. So usually, how does psoriasis present to you? Psoriasis can present to you with erythematous plaques with silvery white scales, silvery white scaling. So once you get this kind of a lesion, that is how you can say that this is going to be psoriasis. अब ये बोलो कि psoriasis, is it more common in the flexural surface or is it more common in the extensor surface? Because there is a predilection to some surface. What is it? Yes, Sakshi is already answering that this is seen more in the extensor surface, and this is seen over extensor surfaces. Extensor surfaces. So that is how psoriasis will present to you. So on the day of the exam, if you get any image, let it be the extensor surface here, let it be the extensor surface over the knee or over the back region, anywhere. Once you get a erythematous plaque with a silvery white scaling, then always go for psoriasis. Now in psoriasis, what are the important things that you will remember is, now before we jump into the histopathology which was asked in this MCQ, let us see what are the important points. The first thing is, what are the signs? What are the important signs in psoriasis? So what are the important signs in psoriasis that you may know? like all of you are messaging in the chat box, can we may just make it interactive? What are the signs you remember? Is there any sign that you remember in psoriasis? Yeah, if there is a trauma to a patient in psoriasis, the patient would be developing a psoriatic kind of a lesion within few days. What is that phenomenon, or what is that sign called as? One very important sign is called as the Koebner phenomenon. Koebner phenomenon. So in Koebner's phenomenon, what happens? New skin lesions, they do develop at the site of trauma. So if I do a skin biopsy for a patient of psoriasis, the patient is more likely to develop a psoriatic plaque lesion at the site of trauma. This is called as Koebner's phenomenon. Can you tell me what are the diseases where we can expect a Koebner's phenomenon? Yeah. So we can expect a Koebner's phenomenon in which all diseases? You can remember it as LVP. What is LVP? Lichen planus, vitiligo, and psoriasis. So these are the three diseases where you can expect a Koebner's phenomenon, that is lichen planus, vitiligo, and psoriasis. So these are the three diseases where we can expect. You can even find this Koebner phenomenon in lichen nitidus as well, isn't it? Lichen nitidus also it is possible. Now, once we are done with Koebner's phenomenon, what is the other very important sign that you can see in this disease? So another very important sign that you can find in this disease, I think all of you have answered it in the chat box already. Yeah, that is called as Auspitz sign. It is called as Auspitz sign. So in case once you do a scraping over the lesion, suppose there is a lesion somewhere here. If I do a scraping over the lesion and then finally you can see some pinpointed bleeding spots. These are called as Auspitz sign. So pinpointed bleeding spots. So pinpointed bleeding spots that you can see on scraping the lesion. On scraping the lesion is called as Auspitz sign. Now, psoriasis is a disease which can affect the joints, it can affect the nails, it can affect the scalp, etc. So when there is multiple different types of presentation in psoriasis, now what is this image showing you? What type of a nail finding can you see in this image right now? So I'm just zooming it for you. So I guess there are two different findings here. There is one finding here and there is one finding here as well. So what are these two findings that you can see in this one image? Yeah, very good. So as Nimra is saying, there is a oil drop sign, right? So this one can be attributed to oil drop sign. So this one can be a oil drop sign. And this oil drop sign is going to be the most characteristic nail lesion in psoriasis. So this is the most characteristic lesion. This is the most characteristic lesion in psoriasis. Now tell me one more thing. Why is the distal part of the nail looking more white here? So is there any separation that is happening? So if there is any separation, no, it is not subungual hyperkeratosis. I agree, Bhuvana, that subungual hyperkeratosis can be seen in psoriasis. But this part of the nail is looking more white because there is distal onycholysis. So what do you mean by onycholysis? The nail is getting detached from the nail bed. So when there is a distal detachment, that part of the nail will look more white in color. So this is called as onycholysis is also seen. Like as others have answered here, what are the other nail changes that you can see in psoriasis? The most common nail change is the nail pitting, isn't it? Nail pitting is the most common nail change. Other than that, I saw in the chat box that somebody has mentioned about subungual hyperkeratosis. Hyperkeratosis. So all these nail changes can be seen in this condition called psoriasis. Can psoriasis involve the scalp? Yes, right. So psoriasis can involve the scalp as well. So whenever a patient of psoriasis would complain to you about any joint pain, at that time, what is your diagnosis going to be? Let us say that in the NEET PG exam, you are getting a question saying that a patient has been taking treatment for psoriasis for the last 5 years. Now the patient complains of a lower back ache. In such a case, what is your diagnosis? Yes, in such a case, your diagnosis is going to be psoriatic arthritis. So any joint pain that is associated with psoriasis, the correct answer would be psoriatic arthritis. Now, few words about psoriatic arthritis. In psoriatic arthritis, what is the most common joint that is involved? What is the most common joint that is involved? Is it the knee joint? Is it the elbow joint? Is it the distal interphalangeal joint? Or anything else? What is it? Yeah, this is going to be the DIP. That is the distal interphalangeal joint is going to be the most common joint that is involved. In psoriatic arthritis, is it a seropositive type of an arthritis or seronegative type of an arthritis? Yes, is it seropositive or seronegative type of an arthritis? It is obviously going to be a seronegative arthritis. It's going to be a seronegative arthritis, isn't it? So now coming back to the histopathology. So when you do a histopathology for psoriasis, so when you do a histopathology of the psoriasis, what are the findings? One very important finding that you should remember for your exam is that there are some neutrophilic micro abscess that is seen in psoriasis. Now, who can answer me what are the names of neutrophilic micro abscess? If I just go back to the same MCQ which we are discussing right now, one of the neutrophilic micro abscess is given in the options. What is it? So hence this is going to be the right answer, that is Munro micro abscess. So it is not just Munro's micro abscess. There is one more neutrophilic micro abscess that can be seen. Can anybody answer what is the other micro abscess that is seen? One is Munro. So along with Munro, there is one more neutrophilic micro abscess. It is by the name Cogoch spongiform pustules. Cogoch spongiform pustule. So these are the two neutrophilic micro abscess which you can see. Now, what is one more finding in the histopathology which has some relevance to the Auspitz sign? Can anybody answer this question? Like, we know that while scraping over the lesion, ultimately we are getting multiple pinpointed bleeding spots. Now, why do we get this pinpointed bleeding spots? Is there anything that you can correlate with the histopathology of the skin? So why does this happen? This is because of not parakeratosis, not agranulosis. You're close, you're close. This is due to the suprapapillary thinning. Suprapapillary thinning that you can see in psoriasis histopathology. Okay, that is because of the suprapapillary thinning. So that attributes to the Auspitz sign. Now coming to the treatment part, in case they test you with the treatment of psoriasis, among all the types of psoriasis of the systemic agents that is available, what is the overall drug of choice in psoriasis? The overall drug of choice in psoriasis is going to be, I'll give you multiple options if you want. Is it methotrexate? Is it acitretin? Is it prednisolone? Or is it azathioprine or cyclosporin? Yes. So the overall drug of choice in psoriasis is going to be methotrexate. So these are some of the basic things that we can discuss regarding psoriasis. Obviously, psoriasis is a very large topic, isn't it? So they can ask you any image. So whatever image you may get, so please make sure that you are able to identify the erythematous plaques with the silvery white scaling, and then identify the Koppner phenomenon, should be able to identify the Auspitz phenomenon as well, and multiple changes over the nails. And what are some of the radiological findings? I saw that somebody was messaging regarding penicillin cup deformity. Like whenever there is a psoriatic arthritis, they can also ask you regarding the radiological findings. So one of the radiological findings is penicillin cup deformity. You can also find a ivory phalanx, isn't it? So all those would be various Radiological findings in psoriasis. Now, in which disease condition can you find this CVT bodies? Option number 2, CVT bodies is also something very common, isn't it? So where do you find the CVT bodies? CVT bodies is seen in another papillosquamous disease. Matlab, there is some plaque disease where you can find CVT bodies. Can anybody make a guess? Very good. Yes, this is seen in lichen planus. This is seen in lichen planus. And how about Portreous microabscess? That is another example of a microabscess. In Portreous microabscess, what is the cell? What is the collection of the cell? Is it a neutrophil? Is it an eosinophil? Or is it a lymphocyte? So is it a neutrophil, eosinophil, or a lymphocyte? Very good. It is seen in mycosis fungoides, I agree. Now, what is a collection of cells? In Portreous microabscess, we can see lymphocytes, a lymphocytic abscess. So, this is going to be lymphocytic abscess. And this is seen in cutaneous T-cell lymphoma. It is seen in cutaneous T-cell lymphoma, also called as mycosis fungoides. Okay, also called as mycosis fungoides. So these are the basic things regarding this first topic. So now moving to the second question now. So moving to the second question, a biopsy from a patient with a flaccid bulla shows acantholysis. What is the most likely diagnosis? बहुत simple सा question है. It's just one line question. Now there is a biopsy which is taken. Now in this biopsy, what you can see is the patient is having a flaccid bulla. So if a patient is having a flaccid bulla, what are the differential diagnosis that comes to your mind? Let us not go into options now. Flaccid bulla, what are the differential diagnosis? Can you name at least two conditions where we get a flaccid bulla, which means a bulla which breaks very easily? Yes, one of the options I can see in the chat box is pemphigus. So this can be due to pemphigus vulgaris, or it can be due to pemphigus foliaceus, isn't it? These two are the very common type of examples where you can get a flaccid bulla. Now, what do you mean by acantholysis? Acantho means which is a cell, it is a keratinocyte. Lysis means separation. So the keratinocytes, they are getting separated from each other. So in which condition is the keratinocytes are getting separated? So which is the condition where you get a flaccid bulla along with separation of keratinocytes? Now, before we go into the option, let me ask you, like, what attaches one keratinocyte to the other? If these two are keratinocytes, how do they get attached to each other? What is that structure which attaches two keratinocytes together? Yeah, this is called as desmosomes, isn't it? So desmosomes, they attaches one keratinocyte to the other. Some of the examples of desmosomes which has a relevance in the diseases which I have written, जैसे pemphigus vulgaris या फिर pemphigus foliaceus, is going to be desmoglein 3 as well as desmoglein 1, isn't it? So now let us see the options now. Biopsy from a patient, flaccid bulla, it shows acantholysis. Now options are pemphigus vulgaris, bullous pemphigoid, dermatitis herpetiformis, linear IgA disease. Easy, isn't it? What is it? Pemphigus vulgaris. Why do we say pemphigus vulgaris? Because we have a flaccid bulla. In all the remaining, जैसे bullous pemphigoid, you would get a tense bulla, isn't it? You will get a tense bulla. Whereas in linear IgA disease, again, there is a BPAG2 defect. You are going to get a tense bulla itself. Now, is there any bulla in this disease called dermatitis herpetiformis? That is the next doubt that I have. Can anybody answer in the chat box? Do we find a bulla in this disease called dermatitis herpetiformis? So let's write down dermatitis herpetiformis. So remember, in dermatitis herpetiformis, we do not find a bulla. What do we find in dermatitis herpetiformis? You have to look for this magic word. And what is this magic word? This is called as papulovesicles. It is called as papulovesicles. Excellent, Bhuvana. So what you find is a papulovesicles. So among all the vesiculobullous diseases, pemphigus vulgaris, pemphigus foliaceus, bullous pemphigoid gestationis, linear IgA disease, all these things will show you a bulla. Whereas if the MCQ says papulovesicles, then the answer should be dermatitis herpetiformis. So in dermatitis herpetiformis, what is this disease very closely associated with? Is there any close association with any disease? Like, does the symptoms of dermatitis herpetiformis worsen when you take some food? Now, what is the name of that disease which is very closely associated? Exactly. This is going to be celiac disease. This is going to be celiac disease. So the patient would be having a gluten sensitive enteropathy. There will be a gluten sensitive enteropathy. So coming to vesiculobullous diseases, let us write down some of the important parts, because what are they going to ask you in vesiculobullous disease? The most commonly asked ones are regarding pemphigus vulgaris or pemphigus foliaceus or bullous pemphigoid or bullous pemphigoid. So these three are the most commonly tested ones when it comes to vesiculobullous diseases. So in this vesiculobullous disease, which of these three are going to show a intraepidermal blister, which means there is a bulla which forms within the epidermis. So this is going to be intraepidermal. Pemphigus foliaceus is also going to be intraepidermal, whereas bullous pemphigoid is going to be subepidermal. Subepidermal, which means it is below the epidermis. Now, do you still remember what is the defect in all these things? In pemphigus vulgaris, if you remember the defect should be in desmoglein. Which desmoglein defect is pemphigus vulgaris? It is usually desmoglein 3 followed by desmoglein 1. Whereas in pemphigus foliaceus, the defect is going to be in desmoglein 1 only, isn't it? And what is the defect that you can find in this condition called bullous pemphigoid? In bullous pemphigoid, it has nothing to do with the epidermis. There is no desmoglein 1, there is no desmoglein 3. Something different is coming up because it is below the epidermis. What is it? Yeah, this is going to be hemidesmosomes. Excellent. So can you name the hemidesmosome? This is going to be BPAG2 more than BPAG1. So that is going to be the defect in bullous pemphigoid. Now, in all the MCQs, I'm sure that in case you get a question about any of these diseases, they would be testing you with a clinical scenario. अब ये बोलो कि what is going to be the clinical scenario in pemphigus vulgaris? Where will the lesions start from? The clue is desmoglein 3 is the defect. So when you have a defect of desmoglein 3, then this desmoglein 3 is present in the maximum concentration over the oral mucosa, right? So please note down this very important point. The symptoms begin in the oral mucosa. The symptoms begin in the oral mucosa. Whereas, where do you find the lesions in pemphigus foliaceus? In pemphigus foliaceus, you get only skin lesions. You get only skin lesions. And bullous pemphigoid, I'm sure that they will definitely mention the patient is having a tense bulla. So here you can get a patient with a tense bulla over the skin. You'll get a tense bulla over the skin. So that is how the clinically it is going to be differentiated. Now, if you have gone through the PYQs in dermatology, you must have seen that in the last two exams, they have been testing you with various investigations. In the last INI CET exam, they asked you Which is the investigation that is used for the diagnosis of dermatological diseases? They gave you multiple options. It was direct immunofluorescence, indirect immunofluorescence. What is it? What is used for the diagnosis of bullous diseases actually? Yes, that is going to be direct immunofluorescence. So what is this investigation that you see on your screen right now? So this investigation is called as DIF. It is called as the direct immunofluorescence. Now, if you do a direct immunofluorescence, what is this first image most likely to be? So this is a peculiar pattern which we call it as the fishnet pattern. You can see that the entire area is the epidermis. The entire epidermis has taken up a greenish fluorescence. And this greenish fluorescence taken up by the epidermis is described as IgG and C3 deposits in a fishnet pattern or a fishnet pattern or chicken wire pattern or chicken wire pattern. Clear? Whereas what do you see in the second DIF? Because in this first DIF, it is seen when the etiology lies within the epidermis. So where do you find this chicken wire pattern? This chicken wire or fishnet pattern is seen in pemphigus vulgaris, or it is seen in pemphigus foliaceus, or it is seen in pemphigus foliaceus. Whereas what you see in the second image, in the second image here, you can see that the DIF or the fluorescence is taken up not in the epidermis. It is not taken up by the dermis also. It is taken by something in between. So what comes in between the epidermis and the dermis? Yes, what comes in between the epidermis and the dermis is called as the basement membrane zone or the dermoepidermal junction. So here you can find that there is IgG and C3 which is deposited linearly over the basement membrane zone or dermoepidermal junction. Now this thing can be seen when the etiology lies below the epidermis. Now what is the disease? The disease should be bullous pemphigoid. Bullous pemphigoid. So for your exam, please remember this direct immunofluorescence finding of pemphigus vulgaris, pemphigus foliaceus as well as bullous pemphigoid. So please tell me main points on Darrier and Haley-Haley. See, Darrier disease and Haley-Haley disease both are inherited bullous disorders, right? So Darrier's easy to remember because you can find dirty, warty, malodorous lesions. So just a minute. So in Darrier's you can find dirty. So I'm just explaining you about Darrier's disease. So in Darrier disease, this is the autosomal dominant in inheritance. Now, once it is autosomal dominant in inheritance, how does a patient present to you with Darrier's disease? Easy to remember. Remember, it looks dirty, it feels warty or rough, and it does not smell good. It is going to be malodorous lesions. And where do you find these lesions? Over the seborrheic sites. Over the seborrheic sites. So does not look good, does not feel good, and does not smell good. This is going to be Darrier's disease. Whereas, how do you get a patient with Haley-Haley disease? Haley-Haley disease is also autosomal dominant. But remember, in Haley-Haley disease, you will be getting vesiculobullous lesions over body folds. Over the body folds. Like body folds as in axilla. So the patient will complain of a vesiculobullous lesion over the axillary area. Then you think about Haley-Haley disease. If the patient comes with a dirty looking, rough looking, bad, foul smelling lesion over the seborrheic sites, then think about Darrier's disease. Is it clear? And there is one more doubt. How do you differentiate from linear IgA disease? So to talk about linear IgA disease, पहले ये बोलो कि linear IgA disease is it common in children or in adults? Remember, linear IgA disease is more common in children. It is more common in children. It is one of the most common bullous disorder in children. Now, in linear IgA disease, when you examine the bulla would be arranged something like this in a circle, in a peculiar pattern. Now, this pattern, they will always mention or compare it with something. What is it compared to? This is compared to a string of pearls appearance, or it is also compared to a cluster of jewel appearance. Cluster of jewel appearance. So if you find a string of pearls or a cluster of jewel appearance, think about like linear IgA disease. In linear IgA disease, what is the treatment of linear IgA disease? That may also be important, because usually for most of the vesicular bullous diseases, we are treating it with steroids. But here there is a small change. Here the drug of choice is going to be dapsone. Here the drug of choice is going to be dapsone. And Nimra, it is not possible. It is not possible to just see and differentiate from the direct immunofluorescence. What happens in linear IgA disease is, just see the name. What is deposited? It is not IgG or C3. IgA is deposited linearly over the basement membrane zone, but you cannot identify it just by seeing the image. You cannot identify just by seeing the image. I hope it is clear. So if there is any queries regarding vesicular bullous diseases, feel free to ask. We'll be discussing it as well. So with your permission, let me go to the next MCQ now. So coming to the next MCQ, which of the following is the most common dermatological manifestation in HIV patients? Now see, I wanted to keep this topic because if you have seen the last NEET PG exam, so many questions had come from this topic called HIV. So you can categorize this under medicine or whichever subject you want, but please make sure that you go thoroughly on HIV, because most probably once it comes left and right, isn't it? So talking about HIV patients and the skin manifestations, the question here is, what is the most common dermatological manifestation? So what is your answer? Kaposi sarcoma, oral hairy leukoplakia, eosinophilic folliculitis, seborrheic dermatitis. Now please remember, the most common dermatological manifestation in HIV patients is seborrheic dermatitis. Okay, don't think that it's a bouncer. It is going to be seborrheic dermatitis. Now regarding HIV, let me just write down few points. So what is the most common dermatological manifestation has been asked in the MCQ? That is going to be seborrheic dermatitis. What is the most common infection in HIV? Infection matlab skin infection. I'm talking about what is the most common skin infection in HIV. Yeah. So what is the most common skin infection in HIV? Any guess? So is it Staphylococcus aureus? Is it Streptococcus? Or is it herpes simplex virus? Or is it varicella? So these are the options I'll give you. Can you make a guess? So the most common skin infection in HIV is going to be HSV. So since HSV is going to be, that is herpes simplex virus, is the most common skin infection. So which means the most common infection, so sorry, which means the most common viral infection in HIV is also going to be HSV, isn't it? Is also going to be herpes simplex virus. Now we are done with virus and the overall common infection. Now let us talk about what is the most common bacterial infection in HIV. The most common bacterial infection in HIV. Any idea which bacteria is going to cause the most common skin infection in HIV. All these are about skin. All these are about skin. So this is going to be Staphylococcus aureus. This is going to be Staphylococcus aureus. So please remember, it is going to be Staphylococcus aureus. Now, can you tell me what is the most common malignancy that is associated with HIV? Most common malignancy associated with HIV. So the most common malignancy that is associated with HIV is going to be Kaposi sarcoma. Kaposi sarcoma. And please remember that 2 years ago we got a image-based question about Kaposi sarcoma. So this Kaposi sarcoma, whichever you see in the HIV patients, what is the color of the plaque lesions? So any idea? Yeah, I agree. It is HHV8. But what is the color of the plaque? So what is the color of the plaque lesions in Kaposi sarcoma? Exactly. You got an image within the oral cavity. That was a question which was asked. So it can be either seen within the oral cavity or it can be seen over the skin. So please remember, it is going to be violaceous plaque lesion. Is going to be a violaceous or a purple colored plaque lesion is what you should expect when it comes to Kaposi sarcoma. There was one more option here, which is oral hairy leukoplakia. So do we see oral hairy leukoplakia also in do we see oral hairy leukoplakia also in HIV patients? Yes. So this can be seen in HIV patients. But remember, what is the virus which can be implicated in oral hairy leukoplakia? Yeah, this is seen with Epstein-Barr virus, isn't it? This is seen with Epstein-Barr virus. So remember Epstein-Barr virus. So what happens in oral hairy leukoplakia? So if this is the tongue, the lateral part of the tongue would be showing you whitish discoloration. So some hairy lesions over the lateral part of the tongue. So that is going to be due to Epstein-Barr virus and is called as oral hairy leukoplakia. Now, among all these things that we have written, right now we wrote overall skin infections where most common is HSV. Most common viral infection is HSV. Most common bacterial infection is Staphylococcus. So we missed out on fungus. So tell me what is the most common fungal infection in HIV patients? So what is the most common fungal infection in HIV patients? Any guess? Excellent. That is candidiasis. So what we call as oral thrush. So what we call as oral thrush, that is going to be the most common. See, Cryptococcus, histoplasmosis, penicilliosis, or all Talaromyces, all these infections can be seen in association with HIV because multiple deep fungal infections can be seen. But I'm asking the most common fungal infection of the skin that is seen in HIV. Here the answer should be candidiasis. Here the answer should be candidiasis. Hairy leukoplakia is not a pre-malignant lesion. No, it is not a pre-malignant lesion. Now, if you talk about pre-malignant lesions affecting the tongue, so let us forget about HIV. Outside HIV, if there is a question, which is the most pre-malignant lesion of the tongue? So if there is a question about the most pre-malignant lesion of the tongue, and if I'm giving you options like leukoplakia, oral hairy leukoplakia, erythroplakia, etc., then what is the most correct answer? Yes, this is going to be erythroplakia. This is going to be erythroplakia. So remember, the most pre-malignant lesion of the tongue is going to be erythroplakia. It is not leukoplakia. It is not leukoplakia. Clear? So please make sure that you go through all these important points regarding HIV because this is one of our frequently tested topics in the NEET PG exam. So with your permission, let me just go further to the next question. So now let's see, a 24-year-old woman presents with a 24-year-old woman presents with a painful genital ulcer. Sang smear shows multinucleated giant cells. Which infection is more likely? Abhi, in this question, what catches my attention is this one, that painful genital ulcer. So for your exam, whenever you get a MCQ of a genital ulcer disease, please try to classify ulcers into painful and painless. Now, how do you remember painless genital ulcer? Painless genital ulcer is by a mnemonic that is LSD. So what is LSD? L stands for LGV, S stands for syphilis, and D stands for donovenosis. And D stands for donovenosis. Just imagine something like this. LSD is a drug. If you take a drug, you will not get to know the pain. इसीलिए LSD is for painless genital ulcer. Now, keeping this thing in mind, the remaining two of the genital ulcer disease, that is painful genital ulcer, will become only two, that is chancroid, and herpes genitalis. Herpes genitalis, that is caused due to HSV. Okay, now let us come back to the question. Patient presents with painful genital ulcer. Zang smear shows multinucleated giant cells. Let us imagine that you don't know about Zang smear and multinucleated giant cell. Let us try to rule out all of the painless genital ulcer. Syphilis, is it painful or painless? Syphilis comes under LSD. So you can rule out this one. Herpes simplex virus, that is going to be painful. Chancroid, that is also painful. And lymphogranuloma venereum, that is LGV, right? LGV is also painless. So what are the two things that we have already ruled out from this MCQ? It is syphilis is also ruled out, LGV is also ruled out. Now you need to decide whether it is herpes simplex virus or whether it is chancroid. Now, where do you find a multinucleated giant cell? Multinucleated giant cells are seen in two different conditions. One is in HSV, the other is in varicella. So please remember, multinucleated giant cells are seen in HSV as well as in varicella. So what is the right answer here? The right answer here should be herpes simplex virus. Herpes simplex virus. Is it clear? Now regarding, I think I have one more question on genital ulcer disease. Let us see that question and then do the further discussion. Yeah, this is the next question. Which organism is commonly responsible for causing a soft, painful genital ulcer and a tender inguinal lymphadenopathy? Now again, mark the important key points. Here again, it is going to be painful genital ulcer or tender inguinal lymphadenopathy. Matlab, this is also painful. Tender means it is going to be painful. So in which condition do we get a painful ulcer and a painful lymphadenopathy? First, let us use our common thing, LSD use karke. Let us rule out the options first. Treponema pallidum, rule out kar sakte hain because that is indicated in syphilis. Haemophilus ducreyi, that is the causative in chancroid, so let it be there. Chlamydia trachomatis is the causative of LGV, है ना? So this one also can be ruled out because here also you get LSD. L stands for LGV, so it is going to be painless. Klebsiella granulomatis, this is a causative of donovenosis, and donovenosis is also painless. See, it worked. Just applying the LSD, you are able to rule out three of the options. So obviously the correct answer here is going to be Haemophilus ducreyi. Now, ducreyi, yeah, na? Crying. So keep crying, that is going to be pain because of the pain. Now, what happens in chancroid is with the inguinal lymphadenopathy, there is pus within the lymph node. There is a pus within the lymph node. So what do we call for suppurative lymphadenopathy? So what is the name that we call for suppurative lymphadenopathy? So this pus within the lymph node, this is called by a peculiar name, that is bullous, that is called as bullous. Okay? Now, in which conditions of, genital ulcer disease can we find suppurative lymphadenopathy or we can find bullous? One answer तो आपको already पता है, that is going to be chancroid. Now, there is one more disease which shows a bubo. Can anybody answer? The one more disease which can show a bubo is going to be LGV, okay? Lymphogranuloma venereum. So remember, these are the two conditions where you can find buboes. These are going to be, these two conditions can show you buboes. Now, among all the genital ulcer disease, the easiest image-based question which can come for your exam is of donovenosis. Why? Because in donovenosis, it has a very peculiar appearance. You see donovenosis, you'll be able to make the diagnosis. The reason is it has a peculiar appearance. What is it? It has a beefy red in color. So the color is going to be beefy red and it's gonna bleed to touch. Okay? So because of that, this is going to be the easiest image-based question when it comes to genital ulcer disease. Is it clear? Okay, so now let me just ask you a few more questions. In syphilis, what do you find? What is the characteristic of the ulcer and what is the characteristic of lymphadenopathy? In syphilis, please remember, you have a painless ulcer because LSD, S stands for syphilis, and there is a painless lymphadenopathy as well. So entirely primary syphilis is going to be a silent disease. There is no pain for the ulcer, there is no pain for the lymphadenopathy. What about chancroid? Exactly opposite to syphilis, I would say. What is opposite to syphilis? Matlab painful ulcer or painful lymphadenopathy. Now, what is going to happen when it comes to LGV? So LGV, again LSD. So it is going to be a painless genital ulcer. So there should be a painless ulcer. But remember, the patient of LGV is going to show you a painful lymphadenopathy. Now tell me, why is the lymphadenopathy in LGV going to be painful? Reason is what I have explained to you a few minutes ago. Let me just scroll up. There is pus within a lymph node. Pus anywhere in the body, just say abscess. It is going to be painful, right? So whenever there is a bubo or a pus within a lymph node, it is going to be painful. That is why in LGV you have a painful lymph node which is called as bubo. And finally, in donovenosis, again apply LSD. D stands for donovenosis. It is a painless ulcer. But remember, there is no inguinal lymphadenopathy in donovenosis. Remember, donovenosis. ये no क्या होता है? There is no lymphadenopathy. Donovenosis has no lymphadenopathy. Instead of lymphadenopathy, it is a subcutaneous swelling which is going to mimic a inguinal lymphadenopathy that can be seen. Abhi bas last one question before we go to the next topic. There is one sign by the name groove sign. So in which condition do we find a groove sign? Can anybody answer this one? Once you are done with this, we'll go to the next topic now. Groove sign of Greenblatt. It is seen in, yes, the groove sign of Greenblatt is seen in LGV, whereas pseudo groove sign is seen in donovenosis. Okay? So that is all about the genital ulcer disease. Once again, a very repeated topic that is always asked. So that is also please important. So please make sure that you go and revise. Okay, now let's go to the next question. अब ये क्या है? What is this? Yeah, all the pseudos, they come under donovenosis. जैसे pseudo genital elephantiasis, pseudo lymphadenopathy, pseudo groove sign, all those things come under donovenosis. Cool. So now let's see this question. A child presents with a pruritic, matlab itchy, erythematous plaques with lichenification on the flexural areas of the arms. Identify the condition. Yes. This is going to be atopic dermatitis. Typical history, correct? Because what happens in atopic dermatitis? It's a very chronic skin disease. Why is it not psoriasis? क्योंकि erythematous plaque तो बोला है. Why is it not psoriasis? Because psoriasis is not pruritic, isn't it? In psoriasis, usually you may not find lichenification, and psoriasis is less likely in a child, isn't it? Contact dermatitis भी नहीं है because there is no history of contact with something that is mentioned in the MCQ. Seborrheic dermatitis is entirely different. So seborrheic dermatitis doesn't happen here. It happen over the seborrheic sites of the body, correct? So that is different. So here, this is atopic dermatitis. Atopic dermatitis, again a repeat topic in NEET PG. In atopic dermatitis, please remember what happens in atopic dermatitis. It is a chronic relapsing skin disease. It is a chronic relapsing skin disease. And where do you look for the lesions of atopic dermatitis? So when you look for the lesions in atopic dermatitis, it depends upon the age. Just say if it is infantile AD, that is atopic dermatitis in infants, then we look for the skin lesions over the face and the extensor surfaces Whereas in childhood as well as in adulthood, in child and in adults, we look for the lesions over the flexures. We look for the lesions in the flexures. Jैसे antecubital fossa, isn't it? That is where we look for the lesions in atopic dermatitis. So now let's go back to this MCQ. You can see that there is a patient who is a child, and the child is having lichenification over the flexural areas. So based on this flexural areas of the arms, the right answer here should be atopic dermatitis. Now one quick question about atopic dermatitis. What is the investigation of choice in atopic dermatitis? Who can answer what is the investigation of choice in atopic dermatitis? So please remember, no investigation is necessary for the diagnosis of atopic dermatitis. So that is the key point here. No investigation is necessary. So why no investigation is necessary for atopic dermatitis? Because it is 100% a clinical diagnosis. And finally, just tell me what is the name of the diagnostic criteria in atopic dermatitis. The diagnostic criteria in atopic dermatitis is going to be Hanifin and Rachka criteria. Hanifin and Rachka criteria. So please remember all these points when it comes to atopic dermatitis. So now let's go to the next question. So this question is, a 45-year-old woman presents with patches of hair loss on the scalp. The affected areas shows scarring and loss of follicular opening. Which of the following conditions is more likely? So talking about this, there is a 45-year-old woman and you can see that there is some hair loss. Now the key point here is there is some scarring alopecia. Now among all the options that is given here, androgenic alopecia, lichen planopilaris, alopecia areata, telogen effluvium, what is the one which causes a scarring alopecia? Yes, So A, C, and D, all these things are examples of non-scarring alopecia. So here, lichen planopilaris, that is the alopecia that is seen in lichen planus, is going to be a scarring type of alopecia. Is going to be a scarring type of alopecia. Okay, so now let us note down some of the examples of scarring alopecia. So what are the examples of scarring alopecia that you know? One is lichen planus, which we have seen in this MCQ. Other than lichen planus, what are the examples of scarring alopecia? Anything that you would like to add? Is it SLE? Because you're saying about SLE, it is not all the types of SLE. I would agree that you're almost correct, because SLE matlab it should be discoid lupus erythematosus. Okay, in syphilis, the moth-eaten alopecia is not a scarring alopecia. Psoriasis, no. Psoriasis also does not lead to scarring alopecia. So lichen planus, discoid lupus erythematosus. I'll give you one more hint. It is a fungal infection. So it's a fungal infection of the scalp. It can be seen more commonly in children. A child may present to you with a painful swelling. Any answer now? Yes, this is going to be cheiron. So cheiron, remember, it is a type of tinea capitis. So this cheiron can also cause scarring alopecia. Other than that, we have pseudopelade of Brock. Pseudopelade of Brock. And also we have anything else? Yes, dissecting cellulitis, all those different reasons also. Okay, so all these are going to be the common examples of scarring alopecia. And remember, anything that starts with A or T is going to be non-scarring alopecia. Non-scarring alopecia, जैसे androgenic alopecia, alopecia areata, trichotillomania, anagen effluvium, telogen effluvium, etc. So all these things can be seen. IgA or IgG increase in atopic dermatitis. See, actually, there is no investigation that is necessary to be done in atopic dermatitis. But what actually increases in atopic dermatitis is IgE. Okay, not A or G. What specifically increases is IgE. Okay. So now coming back to this one. So in the MCQ, also please note that they may mention this term of scarring alopecia as cicatricial alopecia. So cicatricial alopecia means the same. It is going to be scarring alopecia itself. Scarring alopecia itself. So now let's go to the next topic. So this is an assertion reasoning type of a question. So now let's see what is the assertion, that human papilloma virus type 6 and 11 are the most common causes of genital warts. Reason is human papilloma virus 16 and 18 are high risk types associated with the development of cervical cancer. So both A and R are true. Both A and R are true. And R is not the correct explanation for A. What is the right answer? Any guess? Yeah, most of you are answering it as B. So let us see what is given in B. Both A and R are true. Jaise HPV 6 and 11 is a common cause of genital warts, and 16 and 18 are high risk that is implicated in cervical cancer. Okay, the first part is correct. What is second part? But R is not the correct explanation for A, obviously, right? So 16 and 18, what is implicated in cervical cancer, that is not the reasoning for 6 and 11. So this thing is correct. So option B is the right one. Yes, Arjun, we have multiple videos that has been done earlier. Like we have the FMG sprint and all. You can definitely watch it in the MedEd YouTube channel. Thank you. So now let us see about human papilloma virus or this genital warts. What is the other name of genital warts? Can you quickly tell me what is the name of a genital wart? Genital warts, we call it as condyloma acuminata, isn't it? We call this genital warts as condyloma acuminata. Like what has been said in this MCQ, HPV 6 and 11 is considered to be the most common subtype of HPV which can cause condyloma acuminata. Now, HPV 6 and 11, is it a high risk or a low risk subtype? Is it high risk or a low risk subtype? So please remember, this is going to be a low risk subtype. That is the reason why this usually do not proceed into any type of a malignancy. Now, in condyloma acuminata, the point that I want all of you to remember for on the day of your exam is regarding the treatment part, there is no role of antivirals in the treatment of genital warts. Okay? There is no role of antivirals. Like, you must be knowing a lot of antiviral agents, isn't it? But none of the antiviral agents has a role in the treatment of genital warts. So please make sure that you have this concept very clear. Tomorrow, if in one of the options, if they mention the 𝐿-cyclovir is shown to have a good response to condyloma acuminata, wrong. There is no role of antivirals. अगर antivirals का कोई role ही नहीं है, then what is the drug of choice in condyloma acuminata? Drug of choice. Yes, the answer is there in the chat box already. It is called as podophyllins or imiquimod. So these can be used as a treatment of choice for condyloma acuminata. But remember, both these podophyllins and imiquimod, they are going to be teratogenic. So they are going to be teratogenic. If they are teratogenic, we cannot use them in pregnancy. So in pregnancy, what is the drug of choice? Drug of choice in pregnancy is not podophyllins or imiquimod. Then what you will have to do? Yes, in pregnancy, you'll have to go for a cryotherapy. Correct. So in pregnancy, you will have to go for cryotherapy. See, Gajendra, imiquimod and podophyllins both are immunomodulators. So these immunomodulators, they show good responses to condyloma acuminata. That is the reason why we use them as a drug of choice. Okay? And why do we want to treat a mother or an expecting mother who is pregnant now, who is having condyloma acuminata? Because mother can transmit human papilloma virus to the baby. So this transmission to the baby, so the baby will get which type of warts? Is the baby going to get genital warts? Yeah. What is it? In the chat box, please. Is the baby going to get a genital warts or something else? Exactly. It is not the genital warts what the baby is going to get. Instead, the baby is going to get a laryngeal warts. So laryngeal warts in the baby can be transmitted from a mother to the baby. So agar it is laryngeal papillomatosis, then which is the subtype of HPV which can cause a laryngeal warts? Obviously, common sense. Mother is passing on from condyloma acuminata, the thing becomes laryngeal warts. So what is the subtype of HPV that has been passed on? That is going to be HPV 6 and 11. Same. So remember, 6 and 11 is the same thing that is going to be seen in babies who got laryngeal warts. Clear? So now let's go to the next one. Which sign is characterized by the appearance of new skin lesions on the lines of trauma and is commonly seen in psoriasis? So this is a thing, this is a phenomenon which we have already discussed while we discussed about psoriasis. So which is the sign that is characterized by appearance of new skin lesions at the site of trauma? Yeah, that is going to be Koebner's phenomenon. Now, regarding various signs in the skin, this is also very important. Just say Nikolsky sign, Darier's sign, Auspitz sign. Chalo, let us see all these things with images. Your first image, what is this? So this is a patient who probably scratched over the skin, and after scratching they developed this erythematous plaque lesions. So this would be psoriasis, isn't it? This can be psoriasis. and this phenomenon should be Koebner phenomenon. This phenomenon should be Koebner phenomenon. Or a Koebner phenomenon is also having one more name. So tomorrow for your exam, if they give you a name called isomorphic phenomenon, this isomorphic phenomenon and Koebner phenomenon both are the same, one and the same. Okay? Now let us see the second image. This second image में क्या होता है? You can see that there is a dome-shaped papule with a central umbilication. Now, can somebody tell me what is the spot diagnosis of this image? What is the spot diagnosis of this image? Central umbilication. I'll just zoom it out for you. So there is a central depression or a central umbilication in this image. So whenever you find the central umbilication, this is called as molluscum. Very good. Molluscum contagiosum. So in molluscum contagiosum, there is one more phenomenon that can be seen. The baby or a child may get one lesion. The one lesion may become multiple lesions that is followed by each other, isn't it? One after the other. Now this phenomenon is called pseudo-Koebner phenomenon. So this is called as pseudo-Koebner. So why does a child develop one lesion after the other? So the child may develop one lesion after the other because of auto-inoculation of the virus. Because of auto-inoculation of the virus. Okay? That is about pseudo-Koebner phenomenon. It is usually seen in viral diseases. जैसे human papilloma virus infection, that is warts, molluscum contagiosum. All these things can show pseudo-Koebner phenomenon. Now, what is the next sign that is shown? Like if I just apply my finger to give a tangential pressure over the skin. So if I apply a tangential pressure over the skin, and if the skin peels off, what is the sign called as? Very good, Bhuvana. So this sign is called as 𝐒𝐿𝐂𝐝 sign. This sign is called as 𝐒𝐿𝐂𝐝 sign. So Pablo, drug of choice, all of you are answering it. So 𝐒𝐿𝐂𝐝 sign. Now tell me very quickly ki where do we find a 𝐒𝐿𝐂𝐝 sign? 𝐒𝐿𝐂𝐝 sign can be seen in different diseases. First and foremost example can be जहाँ पे you get this flaccid bulla which breaks very easily. जैसे pemphigus vulgaris, pemphigus foliaceus, or there is one more disease which is caused due to the toxins that is released by Staphylococcus aureus. Who can answer this one? In that condition also you can find, very good, you can find this in staphylococcal scalded skin syndrome as well. So in all these things we can find 𝐒𝐿𝐂𝐝 sign positive. Now I saw that some of you are mentioning Stevens-Johnson syndrome. I agree, this is the same clinical sign that is seen in Stevens-Johnson syndrome or toxic epidermal necrolysis. But for your MCQs, remember pseudo-𝐒𝐿𝐂𝐝 sign. Pseudo-𝐒𝐿𝐂𝐝 sign. So in pseudo-𝐒𝐿𝐂𝐝 sign, this can be seen in Stevens-Johnson syndrome or toxic epidermal necrolysis. Why do I call it as a pseudo-𝐒𝐿𝐂𝐝 sign? Is because clinically the sign is going to be the same. So you apply a tangential pressure, the skin will peel off. But etiology wise, it is different. Kyunki in all these three diseases, vulgaris, foliaceus and 4S, there is something that is happening. There is a defect to the desmosomes, like desmosome 1 or desmosome 3 defect is happening. Whereas in Stevens-Johnson syndrome and toxic epidermal necrolysis, the etiology is different. Hence, we call it as pseudo-𝐒𝐿𝐂𝐝 sign. So better you remember it as pseudo-𝐒𝐿𝐂𝐝. Okay? And what is the next image? What is the next image? Like if I'm taking a pen and I'm stroking over the skin. After stroking over the skin, that area of the skin has shown some flares, isn't it? Some urticarial wheals. And you can also see that there are multiple hyperpigmented macules over the skin. Now this is called as Darrier sign. So this is called as Darrier sign. So do you remember what is Darrier sign? This is not dermographism. Dermographism is different. Dermographism, you write something over the skin that may come very prominent. Now in this case, since you can find hyperpigmented macules around the lesion and also some flare-up lesions, this is called as Darrier sign. It is seen in Urticaria pigmentosa. It is seen in Urticaria pigmentosa. So Urticaria pigmentosa is an example of cutaneous mastocytosis. So what happens in Urticaria pigmentosa? See the name, Urticaria matlab wheels. Pigmentosa means hyperpigmentation. So there would be a wheel which has developed, which is healing with hyperpigmentation. That is what happens in Urticaria pigmentosa. And the sign that you can find in this disease is called as Darrier sign. Darrier sign. How about this one? I think this one we had already discussed in the first MCQ itself. When you do a scraping over the skin lesion in psoriasis, there are pinpointed bleeding spots. So this is going to be Auspitz sign. So this is going to be Auspitz sign, which is seen in psoriasis. This we had discussed in the initial part of our discussion. So some of you were talking about dermographism. Now, just two quick questions about dermographism. Let us say there are two common types of dermographism. One is white, the other one is red. So where do you find white dermographism? And where do you find red dermographism? So white dermographism can be seen in which disease? Any idea where do you find white dermographism? Please remember, white is seen in atopic dermatitis, whereas red dermographism is seen in chronic urticaria. So please remember these two. White is seen in atopic dermatitis and red dermographism is seen in chronic urticaria. Chronic urticaria. So now let's see the next question. That there is a 40-year-old gardener who presents with nodular lesions on his arms that ulcerate and form crust. The histopathology of these lesions, they show a star-shaped bodies. Identify the condition. See, all of you are getting the right answer. Excellent. This is called as sporotrichosis. Why do you say it is sporotrichosis? Because the MCQ says gardener. Sporotrichosis is also called as rose gardener's disease. It is also called as the rose gardener's disease. So in rose gardener's disease, what happens? Probably because of a rose thorn prick is one of the common reason. So when there is a prick with a rose thorn, what happens? The patient will develop multiple nodules over the skin. So how are these nodules arranged in the skin? These nodules are arranged linearly. So why are they arranged linearly? Yeah, they are cigar shaped because that is going to be Sporothrix schenckii. So why are these nodules arranged linearly? Because this is running along a lymphatics, isn't it? They are along a lymphatics. So in such cases, if you do a histopathology, you can see a star-shaped body, and this star-shaped body is called asteroid bodies. So these star-shaped bodies, they are called as asteroid bodies. And since it is a deep fungal infection, we will have to treat the patient with oral antifungal agents like itraconazole, for at least a period of 6 months. Yes. So yes, just like what Bhuvana has messaged in the chat box right now, similar thing like what is another deep fungal infection that you can expect for your exam? Another deep fungal infection that you can expect for your exam is chromoblastomycosis. In chromoblastomycosis, what can you find in the histopathology? That is also very important, isn't it? So we can find a copper penny bodies. Copper penny bodies in histopathology. Copper penny bodies, again, there are multiple names. What are the different names of copper penny bodies? This can be called as medlar bodies or sclerotic bodies or muriform cells or muriform cells. So all these are different names of the same entity, that is copper penny bodies. And finally, if you get a question about there is a farmer who comes to you with a swollen foot, and let us see this example. There is a farmer and this farmer is having a swollen ankle, and in this swollen ankle you can see multiple sinus openings, sinus openings, and in this sinus openings there are some discharge of macroscopic grains. So this is actually a triad, another deep fungal infection. What am I talking about? Yes, I'm talking about Madura foot. I'm talking about Madura foot or mycetoma So if you find a image of of a lower leg, a swollen ankle, multiple sinus openings and characteristic discharging grains, then think about mycetoma. Now tell me, is mycetoma purely a fungal infection or can it be a bacterial infection? Yes. So here what you can do is, in Madura food, if it is caused due to bacteria, then it is called as actinomycetoma. Whereas if Madura food it is caused due to fungus, then it is called as eumycetoma. Okay. So that is all about this discussion. So we just rushed through some of the very important topics that is expected in the NEET PG 2024. I hope this short discussion of about 1.5 hours has been useful for you. And I really believe that your preparations are going on track. So I'm very happy the way you guys have responded in the chat box. That is the only reason why this session went well. Thank you so much. And I wish all of you all the very best. Stay focused. Just try to revise all the image based questions or all the common images in dermatology. And before you go for the exam, make sure that you revise all the most probable topics like psoriasis, vitiligo, bullous diseases like pemphigus vulgaris. Along with that, make sure you don't omit sexually transmitted infections like genital ulcer disease, genital discharge disease, etc., including genital warts. So all these are common areas where you are tested. Okay? All these are common areas you are tested. So I wish you all the very best. Okay. And regarding, yeah, skin cancers, I would say that all those three cancers, that is malignant melanoma, where you will be getting a mole, which can be evaluated with ABCDE algorithm. So any atypical mole can be malignant melanoma. That is one. The second thing is, whenever you get a lesion over the face in an elderly patient, more likely to be basal cell carcinoma, because that is the most common skin malignancy, isn't it? So these two are very much likely when it comes to skin malignancies. Okay. So thank you so much for your patience and wishing you all the best. Do let us know once the exam is done, and wishing for great results this time. Thank you so much.